Papadakis from St. George's Hospital in UK, who will speak about prerequisites for return to competitive exercise after myocarditis. Does the existence of myocardial fibrosis matter?
Fantastic. I hope you can hear me well.
Papadakis.
No worries. I've been called Manolis lots of time because my brother and my father are called Manolis, so I'm used to it. So thank you very much for the kind invitation. I would like to thank Professor Filippatos for the very kind invitation to participate in this particular table. And it's an honor to go after Professor Keren and Dr. Anastasakis. Now, they've said most of the things related to myocarditis, so I'm not going to repeat all that. And I'll focus only on exercise prescription. These are my conflicts of interest, which are not particularly related to this talk. And the way I will outline the session is I've got two clinical scenarios for you because I think we all learn better from clinical scenarios. I will try to answer the question whether myocardial fibrosis matters in terms of exercise prescription and outline the exercise recommendations and give you a very practical approach of how I go about prescribing exercise or recommending competitive sport to athletic individuals after myocarditis. So here we've got the first case. It's an 18-year-old elite judo player who competes at international level. He trains 14 hours per week, and he presents essentially with a 24 to 48-hour history that he's been feeling feverish and unwell, and he started experiencing chest pain after his training. He did try to persevere, but the pain was significant, and he decided to come to his local A&E. There is no significant past medical history or family history of note, and the previous speakers have highlighted the importance of past medical history and family history in all cases. Now, this is his 12-lead ECG, and I hope you'll all agree that it doesn't look particularly exciting. He had blood tests that demonstrated a slightly elevated white cell count, an elevated CRP, and a slightly elevated troponin T of 125 nanograms per liter. So he went on to have a transthoracic echocardiogram that was very, very unexciting in terms of the size, in terms of the function of the ventricle, in terms of the absence of regional wall motion abnormalities, and they only noted a trivial pericardial effusion, but nothing more than that. And then he went on to have a cardiac MRI where it was noted that his volumes were in the upper limits of normal, with a low normal systolic function, which will not be unusual in the context of an elite athletic individual. And overall, they felt that there was a bit of increased to stir signal in the mid-lateral wall and the associated pericardium, but no overt late gadolinium enhancement. So essentially, this individual was assigned a diagnosis of a mild form of myocarditis. He was actually prescribed ibuprofen for a week to take it consistently and then taper it off for chest pain relief. And he was advised to abstain for 3 months from competitive judo as per standard guidelines. Now, the reality is because he had competitions coming on and he was very anxious to go back to his training, he actually came back after 8 weeks. He had already been doing light training for 3 to 4 hours a day. He was completely asymptomatic. He got his repeat testing, which was essentially unremarkable. And then he had an exercise test that was a standard Bruce protocol rather than a graded protocol of 18 minutes with good heart rate response, no symptoms, and no evidence of any arrhythmias. And I will invite you to have a think as to what would you do in this particular individual in terms of him returning to competitive judo. And we'll come back to it at the end of my presentation. Now, the second case is a bit more challenging because it's a 22-year-old competitive football player where he gets admitted with worsening chest pain. Again, he's been feeling unwell for 2 or 3 days with coryzal symptoms and fever. He has no significant past medical history or family history of note. He has his blood test as the previous one, and again, the white cell count is elevated. The CRP is a bit elevated, but here you can see that he's got a very significant troponin T elevation, which is more than 50,000, which is the sort of troponin Ts that you see in acute myocardial infarctions, and mildly deranged liver function test. Now, I think you will agree that his ECG does not look particularly exciting. The most exciting thing is the fact that he's tachycardic, particularly for a 22-year-old who is quite athletic. And then he had his transthoracic echocardiogram, and this is the true transthoracic echocardiogram that was done in A&E during his admission. And you have his long axis views and his short axis views, and you can make your own conclusions as to whether you're able to view any regional wall motion abnormalities. In the long axis view, you may be wondering a bit about the lateral wall and also the basal inferior and inferoseptum. But to be completely honest with you, when you look at your short axis view, that's not necessarily confirmed. And overall, the size and the function of his left ventricle appears within normal limits. And there was no evidence of any significant pericardial effusion. He goes on to have a cardiac MRI where the left ventricular size was reported as normal. His ejection fraction on MRI was reported as mildly impaired with an ejection fraction of 52%, with a lower limit of normal being the 57%. There were no overt regional wall motion abnormalities, and the right ventricular function was reported as normal. And then he gets the late gadolinium enhancement. And as you can clearly see, you don't need to be an MRologist to interpret those images. I've got for you the 4-chamber, the 2-chamber, and the 3-chamber view. And you'll see in the fluffy white aspect of the black myocardium that there is extensive myocardial enhancement that affects predominantly the lateral and the inferior wall, but it's present as well on the anterior wall and at the apical septum. And that was associated with increased T2 stir image and elevated T2 values in the T2 maps that were performed prior to the contrast admission, which suggests significant acute inflammatory process. So this individual got a diagnosis of acute myocarditis. Again, he was prescribed some ibuprofen and colchicine. And he was also prescribed some bisoprolol and ramipril, and I'll be interested to see what the practice of other people are in terms of prescribing heart failure-related medication in someone who has extensive myocardial fibrosis and only mild left ventricular dysfunction, which was not quite recognized on the transthoracic echocardiogram. He was definitely advised, given the extent of the myocarditis, to abstain for 3 months from any exercise, apart from light intensity physical activity. Now, this guy came back after 3 months, where he had been doing limited exercise in the very light intensity and a bit of lightweight training. He was completely asymptomatic. His repeat bloods, his ECG and his transthoracic echocardiogram were normal, and he also underwent an exercise test and a Holter monitor that demonstrated only occasional monomorphic ventricular ectopy coming from the lateral wall. Now, on his repeat cardiac MRI, the left ventricle was reported as normal size with normal systolic function, which was known at that 57 low normal range, with no overt regional wall motion abnormalities. The inflammation markers were down, and this was his late gadolinium enhancement. And I'll put for you so that you can compare the initial images. So you can see that although a lot of the gadolinium has resolved, because a lot of the inflammation has resolved, there is still quite significant gadolinium enhancement, which indicates myocardial fibrosis in the post-acute phase that affects the lateral wall, predominantly the lateral wall, but also the inferior wall as in the first scan. So the question obviously here is, what are you going to do with this chap, and how is that going to differ in terms of your exercise prescription compared to the first scenario that I presented to you? And we will come back into a second. Now, in terms of the pathogenesis of myocarditis, Professor Keren has already shown you that slide. All I will mention is that our concern with exercise, definitely in the acute, but also in the chronic phase, is whether the inflammatory infiltrate, the myocardial necrosis, and the eventual fibrosis, putting on top of it intense exercise, can potentially predispose to malignant arrhythmias and sudden cardiac arrest, as in this particular case. Now, we know from different data sets, and that includes Italy, the US registries, and in athletic and non-athletic individuals, that if we look at the prevalence of myocarditis in terms of sudden cardiac death, it's anything between 5 and 10%. And as Professor Keren highlighted, that we need to take myocarditis seriously, because even if sudden cardiac death is not our main concern, the prognosis of the condition can be quite dire, with up to 25% developing persistent cardiac dysfunction, and even of up to a quarter of patients, depending on the individual case, progressing to an overt dilated cardiomyopathy phenotype and even requiring heart transplantation. So it's nothing to ignore. Now, because we're discussing myocardial fibrosis, I wanted to emphasize the role of cardiac MRI, which has already been emphasized by Professor Keren. And this is an excellent review for you to have a read if you wish to. And we started with using cardiac MRI in terms of essentially of the TT-weighted images, which I have to say sometimes can be very challenging to interpret. And sometimes the interpretation for a clinical cardiologist like myself depends on the clinical history. Then we went to the late gadolinium enhancement, but now we've got far better tools as well that are getting more and more improved as the time goes by, and both have been mentioning in terms of the T1 mapping and measuring the extracellular volume of our myocardium, and T2 mapping, which is dedicated to the presence of myocardial inflammation. And it has already been highlighted that there are other potential tools that are used more on a research basis in terms of myocardial strain, ventricular strain, and atrial strain that may come into play gradually as our knowledge improves and progresses. But it's also important to highlight that it comes with challenges, and you will all remember the COVID era and the post-COVID era, where some studies ended up saying essentially that most individuals who had COVID infection had a degree of myocardial inflammation, which proved to be completely wrong. Now, what are the studies that are available very quickly? This is one of the first studies by Grun et al., where they took 200 individuals with myocarditis that was biopsy proven, and the presence of late gadolinium enhancement in this particular cohort was about 50%. And what they demonstrated that in terms of predicting cardiac death, aside from the ejection fraction, the higher ventricular volumes and symptoms, late gadolinium enhancement had a very significant prognostic significance, and with 3% annual cardiac mortality and 13% fold increase of cardiac death independent of symptoms. So myocardial fibrosis does matter, and exactly the same message from the same study in terms of the sudden cardiac death rather than cardiac death alone, which is predominantly what we're worried about for athletic individuals. After that study, we have the study by Grani et al. That they looked exactly at the same thing, the prognostic value of cardiac MRI, and particularly late gadolinium enhancement in suspected myocarditis. They had a bigger cohort, and they looked at major adverse cardiovascular events, and essentially their message was very similar, and they highlighted that if you had gadolinium present in the acute phase of the myocarditis, then you were almost twofold higher risk for MACE and for death compared to individuals who did not have late gadolinium enhancement. And they also highlighted that the gadolinium enhancement made quite a difference in terms of prognosis, particularly for the individuals who had fairly preserved or mildly impaired left ventricular systolic function, as you can see with the two blue lines at the top of the diagram. And the last main study was the ITAMI study by colleagues in Italy, where they looked at almost 400 individuals. What they did, they took individuals who had preserved ejection fraction. So they took the reduction of the ejection fraction out of the prognostic significance. Again, they had pretty robust endpoints. And what they highlighted in this study is that the presence of late gadolinium enhancement did make a difference, but it was also where that late gadolinium enhancement was, highlighting that the presence of gadolinium enhancement in the anteroseptum seems to have quite significant impact on prognosis compared to late gadolinium enhancement in the inferolateral wall, which is the most classic phenotype that we meet. And as you can see from this table, the resuscitated cardiac arrest, the appropriate ICD shocks, and the hospitalization for heart failure were predominantly in that particular group where they had anteroseptal pattern of gadolinium enhancement. And I'll briefly mention that the same group went back to the same cohort to look at whether we should be repeating the cardiac MRI at 6 months' time as its regular practice, and how that may influence our knowledge in terms of prognosis and therefore our clinical practice. So they managed to get a repeat MRI in almost 200 of the 400 individuals that they had from the first cohort. And essentially, what they highlighted is that the edema resolved in the great majority of cases. Late gadolinium enhancement, on the other side, persisted in the majority of cases, with only 10% late gadolinium enhancement resolving completely. And there was a significant influence in terms of prognosis with those who did not have late gadolinium enhancement compared to those who had a late gadolinium enhancement, and particularly if that late gadolinium enhancement appeared more extensive or more prominent compared to the first scan. So let's go then to the evaluation of the myocarditis in athletic individuals. So I've said to you already, and you saw in my two athletic individuals, that as per the non-athletic individual, we will look at the clinical picture, we look at the biomarkers, we look at the ECG and transthoracic echocardiography. I have to say in our institution, a cardiac MRI, we can get it quite quickly. If not the same day, it's going to be the next day for our inpatients. But that's not the reality in all centers. It's important to keep that in mind. And then if we make our diagnosis and we're satisfied with our diagnosis, we will bring people in 3 to 6 months' time for a re-evaluation. And this is the way I go about it, having looked at the guidelines in terms of the myocarditis. And essentially, what I would like to highlight is that during your re-evaluation, you look at symptoms, you look at the cardiac biomarkers, you do your ECG and your echocardiography. If those are abnormal, then you need to reconsider things and definitely consider the eligibility, particularly for high intensity and competitive sports. If the first line evaluation is normal, then you can proceed to a cardiac MRI in terms of deciding eligibility. And if there is active inflammation, and as I explained already, now we're better at appreciating active inflammation on cardiac MRI, then again, you need to reevaluate things and the athlete will not be eligible for high intensity and competitive sports. If there is no active inflammation, then I've separated them to those who are gadolinium positive, like the second athlete that we presented to you. And obviously here the question is, what's the significance of it? And to try and answer that question, the two tools that we've got available, potentially the volume, so how extensive is the gadolinium enhancement, and what's the site of gadolinium enhancement, because I told you that studies indicate that anteroseptum may be more significant compared to the gadolinium that we find in the inferolateral wall. And then depending on those findings, one may decide for eligibility or not. I have to say that at this point, the guidelines are not particularly clear. There is text there. that combines the ejection fraction with arrhythmia and the volume of myocardial enhancement. And I think the text is there because obviously there is quite a bit of difficulty of people saying that based on gadolinium enhancement alone, I will exclude someone from competitive sports in the absence of symptoms, in the presence of normal systolic function, and in the absence of significant arrhythmia. So my practice will be that for both groups, if I'm satisfied that there is no acute inflammatory component, I will proceed with exercise test, maximal exercise testing. And if I'm satisfied with that, I will also do an ECG monitoring. And ideally, you want to do your ECG monitoring in the community. And then as your athlete starts going back to their own sport, training and games, you want to monitor with repeat ECG monitors. And nowadays, we do have patches that we can use that allow us to monitor athletic individuals during exercise, because obviously your lab does not necessarily reproduce what happens in the football field. Now, if there are significant arrhythmias, and you may come and ask, well, what do you mean by significant arrhythmias? And again, things that are exercise-induced, you have to look at the frequency, and you have to look at the complexity of arrhythmias. Do you have non-sustained VTs? Do you have multifocal ectopy? So on and so forth. So that may be things that make you consider as whether the player is eligible or not. But in the absence of significant arrhythmias, then you get them back to a structured training program and they can be eligible for competitive sport. So that's in summary roughly what the guidelines currently say from the European Society of Cardiology. Now, I want to highlight that the more you learn about myocarditis and cardiomyopathies, as Professor Keren and Dr. Anastasakis highlight, I think the more humble you become in terms of the things that you think you know, and the things you don't quite understand. So it is important to have that shared decision-making for our athletic individuals, particularly those that do not present with very high-risk features such as left ventricular dysfunction and very concerning arrhythmias. And please don't forget that particularly for athletic individuals who exert themselves at high level, regular monitoring is necessary. And sometimes, like the second athlete, for example, you may require annual follow-up for many years to come. And sometimes things may reveal themselves to you during the follow-up time. And the thing that always worries me and I'm looking hard for with exercise testing and ECG monitoring is the presence of arrhythmias. And please don't forget that the fact that someone doesn't have arrhythmias doesn't necessarily mean that they're not at risk, as we demonstrated by those studies. So appropriate education of your athlete in terms of symptoms they should look out for, and appropriate education of team doctors and emergency response planning, which should be present, to be completely honest with you anyway, is necessary. So what we advise, usually what I do with the athletic individuals, I go through my baseline of explaining benefits and potential risks of exercise, give them the minimal physical activity and potential benefits of high volume of exercise, and this is useful for all your patients. Encourage them potentially, if I'm concerned, to continue with more sustained endurance training rather than high intensity start-stop sports like football, and then assess the athlete's wishes. Now, in this particular case where we had competitive athletes, case one, I think, was a relatively easy case because there was a very mild form of myocarditis that resolved quite quickly. So he went back to competitive judo soon after his second assessment. He remained under follow-up for about a year, and then he was discharged. But for the second one, which had a more disturbing picture on his cardiac MRI, we stopped the medical treatment at 3 months as his indices had normalized. He resumed exercise gradually, and then we repeated all the investigations after 6 months to ensure that everything remains stable and his LV function had not come down. And he went back to competitive football, but remains under regular follow-up, and he will remain under long-term follow-up on an annual basis. And before I finish, I just wanted to say that if you're really interested in sports cardiology and cases like that, have a look at the MSc that we run at St. George's University of London. And we also have our annual sports cardiology conference in London that you can join face-to-face or remotely if you wish. And I look forward to seeing you in Milan, where we've got our ESC Preventive Cardiology 3 to 5th of April, where we address sports cardiology amongst the group of preventive cardiology. Thank you very much for your attention.
Thank you, Michalis, for this very nice presentation and also with very useful instructions for the monitoring of these patients. Is there any short comment or question?
Michali, can you hear me?
Yes.
Okay. We have a problem, though, with young people which they go and they had an CMR because, for example, they had abnormal ECG or mildly abnormal ECG. The rest of the evaluation is fine. I mean, Holter, echo, exercise test. But in MRI, they find, for example, fibrosis 4% or 2% or 3%. Now, how we deal with these people? Are we going to exclude them from athletic activity? Because we know that when we have, abnormal ECG or mildly abnormal ECG, and the rest of the evaluation is fine, we allow them to continue and we follow up them. So, what's your practice in this very mild fibrosis?
So my practice is exactly as I explained in that flow chart, Aris. In terms of whether they're gadolinium positive or gadolinium negative, I will proceed by maximal exercise testing. I will do my ECG monitoring, and I'm predominantly interested in arrhythmia. If I don't see any arrhythmia, and as I said, you may ask, what do you mean by arrhythmia? And I try to explain in terms of exercise induced, how frequent it is and how complex the arrhythmia is. Then I'm fairly reassured. That does not mean I'm going to discharge them. I'll keep an eye on them as I did with the second one, who had more extensive than what you described. But they will definitely continue with competitive exercise and sports in our institution.
Μιχάλη, επειδή δεν έχουμε ξένους, μια τελευταία γρήγορη ερώτηση. Τι λες για το NT-proBNP στην παρακολούθηση αυτών των ασθενών? Έχουμε στοιχεία?
Δεν το έχω χρησιμοποιήσει πολύ για να είμαι εντελώς ειλικρινής, οπότε δεν έχω ιδιαίτερη εμπειρία.
Υπάρχουν μερικά σουηδικά μοντέλα για τους αθλητές ειδικά, που νομίζω ότι μπορεί να γίνει extrapolation και στους αυτούς που ασκούνται.
Απλά γενικότερα όταν έχουμε προσπαθήσει στο δικό μας group να χρησιμοποιήσουμε το NT-proBNP και κυρίως το έχουμε προσπαθήσει σε διαφοροδιάγνωση διαιτατικής, για παράδειγμα, με καρδιά αθλητή, αριθμιογενού με καρδιά αθλητή, δεν το έχουμε βρει ιδιαίτερα χρήσιμο.
Okay. Ευχαριστούμε, Μιχάλη, σε ευχαριστούμε και συνεχίζουμε.
Να είστε καλά.